Good morning. Welcome. My name is Margarita Correa Mendez. I am a program director in the Research and Training branch at the NCI Center for Global Health. Thank you for joining us today for our Global Cancer Research and Control Seminar Series that features talks by researchers and cancer control experts working in global oncology and provides an opportunity for discussion and collaboration on impactful and innovative work that addresses cancer morbidity and mortality worldwide. I am delighted to welcome Dr. Martín Lajous from the National Institute of Public Health in Mexico. Today, Dr. Lajous will discuss how researchers in Mexico, both at the National Institute of Public Health and broadly, are tackling the burden of cancer through epidemiologic research and program development. Dr. Lajous received his MD from the National Autonomous University of Mexico and a master's and doctoral degrees in epidemiology from the Harvard T.H. Chan School of Public Health. Currently, Dr. Lajous acts as a faculty researcher at the National Institute of Public Health in Mexico and an adjunct professor at the Harvard T.H. Chan School of Public Health. At the National Institute of Public Health, Dr. Lajous helped design and develop the Mexican Teachers Cohort and now serves as its principal investigator. The cohort has since become part of the U.S. NCI Cancer Cohort Consortium. Dr. Lajous teaches courses on cancer epidemiology, causal inference, and implementation science, and he is primarily interested in cancer epidemiology and the implementation of cancer prevention and control programs. And so before handing over the session to our speaker, I'd like to review a few logistics. First, please save your questions for the designated Q&A time that we will have immediately following Dr. Lajous' presentation. You may type your questions in the chat box as we go. Or towards the end in our Q&A session, we welcome you raising your hand, which is a feature found under the reactions group. Second, please note that today's presentation is being recorded and will be available at our website, cancer.gov/global health. Finally, you can find information about future presentations on our website, cancer.gov/global health, and by following us on X at NCI Global Health. And now please join me in welcoming Dr. Lajous to his presentation today. Thank you for being here again.
Hello. So thank you so much for that very kind introduction. I'm really thrilled for doing this presentation with you. Today I'm going to talk about some epidemiologic research and some program development that's been going on in Mexico. These, of course, are projects that I have been personally involved in. There's a lot of work going on in Mexico in general in cancer research. I have a lot to say, so I'm going to try to keep the time allotted to me. But I'm leaving there so I'm going to breeze through, I think, a lot of things. But I'm leaving there my email. Yeah, because if there's any further inquiries on the work that we're doing, I can certainly provide more detail. So I wanted to start with some of the motivating questions for today's talk, and who are people who have been involved in resolving those questions. So the first one is carbohydrate intake a risk factor for breast cancer in Mexico? And this work has been led by Dr. Gomez from our institution. We're also going to talk about why is there try to respond to the question why there's a unique epidemiological pattern in hepatocellular cancer in Mexico where women and men are equally affected, and this has been led by Adriana Monge. And also, finally, we're going to talk about how we're thinking about implementing colorectal cancer screening in Mexico, and this has been led by Dr. Priscilla Espinosa and Dr. Carla Unger. I really want to, acknowledge the work of these fantastic women researchers doing all this work in Mexico. So to kick off, in 2004, there was this publication. This is work that's led by Dr. Isabel Romiu, using a population-based case control study in Mexico. And in a collaboration with Dr. Walter Willett, they found that carbohydrate intake was associated with breast cancer. Now, this publication is associated to my personal story because I was studying my master's degree when this was published, and I was actually present in Dr. Walter Willett's office when he started getting calls from different media trying for him to comment on these results, because this was an observation. Carbohydrate intake was not at the time an area of interest for breast cancer. However, the results from this study were highlighted in different media sources. And really, I think this was a motivating question it became a motivating question for doing more research in breast cancer risk in Mexico. I got involved with this effort, and we worked on trying to further characterize the impact, in another way, of carbohydrates and breast cancer. Again, using the same case control study. We found that rapidly absorbed carbohydrates were associated to breast cancer. Again, this was coming from I think a very robust case control study, but still there are questions on whether this would be true in a prospective setting. So why would carbohydrate intake be something to study in Mexico? So first of all, and one of the reasons that we identified as potentially as why we were able to detect the signal in Mexico is that there is a really wide range, a much wider range of carbohydrate intake relative to other places, other populations. 64% of energy intake in adults comes from carbohydrates. This is close. This was at the time, and it's closely what we see right now. And as you may know, sugars and beverage intake is really, really high in Mexico, and it represents a significant proportion of the energy intake. Also, there's increasing interest on understanding cancer risk factors and mechanisms in Hispanic women, in other populations. We know the ancestry may affect the impact of certain environmental exposures. Also, I think this work is important because it may help support some of the policies that Mexico has implemented to encourage healthier environments, including taxing of sugars and beverages and front of package food warning that identifies, for instance, added sugars in products across Mexico. So I would say that this was a question that really motivated the establishment of the Mexican teachers cohort, which is this cohort that began in 2006 and 2008. With support from the American Institute for Cancer Research and CONACYT. This is a cohort, 115,000 women strong. The reason we chose teachers was, because of the job stability, because they were really accustomed in this setting to respond to optically read questionnaires. And I think the most important reason that now we're seeing, or the rationale for doing the cohort within teachers, was that these teachers by law all are part of a social security system. And again, because there's job stability, we thought that we would in the future be able to use medical records from these institutions to identify different health outcomes, including cancer. What type of data do we have in the cohort? Just briefly, we have, I like to sort of say that the cohort is really has a combination of both information similar to what you get in, say, the nurses' cell study, where you have questionnaire-based information, but also we have a clinical sub cohort where we have more detailed clinical information, including mammographic density and different biomarkers. And we have a small and still unfortunately underused biorepository in around 7,000 women. We've done a lot of work to validate the self-reports, the self-reported data. We've done so for anthropometry, physical activity, and we're really currently doing it for the food frequency questionnaire. And I think one really important thing that we've been able to achieve for the future is that currently we have geocoded close to 100% of participants in our cohort. And uniquely, we also have information on the location of where women work. I won't spend much time here, but this is how we do the follow-up. Unfortunately, we originally wanted to do it similar to many of to the nurses' cell study, where you do follow-up every 2 years. Unfortunately, due to limitations in funds, we have been really unable to do that. However, we did do a first follow, a second follow-up, and now we're doing our third follow-up. And again, we have been limited in our capability of really getting to a high response rate because of some financial limitations on being able to deliver the questionnaires to participants, particularly women who have who no longer are active teachers. And this, I would say, to me, is really key to the work that we've done in cancer, which is being able to access electronic health records, electronic medical records, and registries. And I won't spend too much time here, but these are the data sources that we've used for cancer case identification. And just we estimate that we have access to databases over our coverage is around 96% of participants in terms of electronic health record data. For breast cancer, we did this approach where we developed a algorithm using multiple data sources within one of the major health systems there, which is ISTE, and we developed a breast cancer ascertainment algorithm that we were able to validate and found to really be useful to identify cancer cases. Now, doing this, we were able to we started out with information from mortality registries where we identified cancer cases. We also had self-reports, and also these multiple registries and electronic health record data sets. And using these, we were able to confirm around 1,300 breast cancer cases between 2006 and 2019. What we first did is we really wanted to understand, are we really getting cases? I believe that we probably are underestimating or have missed some cases, but we're still working on including those who we're not able to validate. But as you can see, when we estimated the incidence, we found it to be higher than the reports from different sources, which are GlobalCan, the Global Burden of Disease, and Medida. These are again comparable because it's an age-adjusted, age-standardized incidence, and so therefore we believe. We understand. We expected this to be higher because these are women who are working, but this sort of allows us to give you some external validity of our breast cancer ascertainment process. Another thing that we've done is really trying to see whether we find the expected associations with established risk factors with breast cancer. And this I'm giving you a selected group of risk factors. So as you can see, for instance, there's an association with family history of breast cancer, benign breast disease, age at menarche, OCUs, and other reproductive factors. Now, really, again, to try to coming back to the original question, I mean, what do we know about carbohydrates and breast cancer? Again, these are results from several cohorts that have tried to address this. And with the exception of the most recent French cohort, which is the Nutrinet, really there's not a lot of evidence in studies conducted in the US or in European populations. These are results from Nutrinet are really the newest results we have on this. And then, since then, since 2005, there's a new population-based case control study was conducted, was established in 2004. And that population-based case control study also supported the possibility that carbohydrates could be associated particularly to premenopausal breast cancer. Again, these observations being made in a population where it's generally understudied. And for instance, the World Cancer Research Fund still does not considers there's limited information on the impact of carbohydrate on breast cancer. So I think that understanding this relation in the Mexican population is still very, very relevant. Thus, we first looked at glycemic load and glycemic index. I'm just showing you here results for glycemic load. And we found an association between, generally speaking, carbohydrate quality and breast cancer risk, particularly in premenopausal women. And these are really, I think that one of the important also contributions of the Mexican teachers cohort is that we have, because teachers were recruited at relatively young ages, we have an important proportion of the breast cancer cases in premenopausal women. So when we did this analysis, we also identified that one of the major drivers of the quality of carbohydrates consumed by the teachers were sugar-sweetened beverages and pastries. So we decided that, and also in terms of public health, of research that supports public health measures, we decided that we were going to, instead of looking at carbohydrates overall, we're going to concentrate really on added sugars, which again are really important in terms of the policies being implemented in Mexico to limit or to promote healthier food environments. So these are results from our analysis on added sugars. And as you can see, we found that an association between added sugars and particularly premenopausal breast cancer. Again, just wanted to make there's another two cohorts that have actually looked at added sugars, are the WHI, which found no association, and Nutrinet, again, this French cohort that did find an association. So as you can see, in Mexico, we do have an opportunity to study this risk factor because, again, the distribution may be much wider than what we see in other populations. I do want to, in terms of the public health implications, I think that this, responding to this first question on the importance of carbohydrates in breast cancer really puts the Mexican teachers cohort or makes a clear resource for cancer research in an understudied population. We're still doing more research. We will be conducting more research on breast cancer. We're also in the process of identifying ovarian, colorectal, and endometrial cancers. And I do want to stress that this is possible because we've been able to identify key partners over a history at the, over time in the Mexican teachers cohort. I mean, this was, Walter Willett was really generous with his time when we first designed, and we were able to understand how to operate a large-scale cohort. I do want to point to Lisa Signorello, who was at NCI some time ago. She, at her time at Harvard, she really pushed us forward into ensuring that we had high quality data. So she was also really involved. And now more recently, Britton Travert from University of Utah has been working with us on ovarian cancer, and I think she has really provided a lot of support for the cohort. I think also the work really may strengthen may help to strengthen the policies in Mexico. So moving on to liver cancer. So again, I do want to acknowledge that some time ago we received funding from NCI to develop a regional center for research excellence. However, this program was stopped, but this initial funding allowed us to identify an important cancer outcome that was really, I think, understudied and under the radar in Mexico, which was liver cancer, as well as allowed us to engage and identify partners for doing this research, which is specifically Dr. Catherine McGlynn and all the folks at INCAP in Guatemala who have been working in liver cancer. So what do we mean by a unique epidemiologic pattern? So here we started out by looking at the descriptive epidemiology of liver cancer mortality in Mexico. And here what we found was that there's an important substantial heterogeneity. And what we saw was that there's a higher burden in more rural states, which was unexpected. Also, we saw that apparently, and this is, we did a male to female ratio across different regions in Mexico. And generally, we found nationally that the male to female ratio was 1, which is unexpected, as normally this condition affects, like, sometimes 3, depending on the population, 3 to 6 times more men than women. So again, looking at the burden of the disease, this is the 3rd cause of cancer mortality in Mexican women. And again, I presented results from different areas in Mexico. And these are results from our population-based cancer registry, which is only in Mérida and the Yucatan. And it doesn't seem to track as well as this one-to-one relationship between men and women. But again, this is a very specific area, but I do want to acknowledge that. Now, what do we know about liver cancer risk factors in Mexico? And again, this is part of the unique pattern, is that viral factors are relatively uncommon. Excessive alcohol intake is really urban and it's stable. It hasn't been increased over time. However, there's been a clear rise in metabolic abnormalities, which are linked to fatty liver disease, which has been linked to liver cancer. Now, aflatoxin, as a lot of you may know, aflatoxin is an important carcinogen as defined by IARC. This is based mostly on observational studies that were conducted a long time ago in China and Africa. And one of the key things is the identification of a mutation that's specifically associated to the exposure to aflatoxin. What did we know about aflatoxin exposure in Mexico? We had some information that aflatoxin contaminates maize, which is a staple food in Mexico. And they're in small studies in rural Mexico. There was there in initials. These are very small studies. They did report a really basically a ubiquitous exposure to aflatoxin. And there had been, this is a study, this pretty old study in 1996 that showed that there was a high prevalence of this mutation in liver cancer tumor blocks in northern Mexico. The other important piece of information is that aflatoxin had been widely studied in Guatemala. Again, and we know that Guatemala is one of the countries with the highest liver cancer burden in the continent. And so this because Guatemala borders Mexico, we thought that this might be important in Mexico. So we did a small pilot. This pilot basically looked at aflatoxin levels in Mexico using a small sample in Chiapas. This is a state that borders Guatemala, and these are samples that had been previously collected from the Mexican National Health and Nutrition Survey, and we found a very high prevalence of detection of 86%. And however, relative to Guatemala, the circulating levels were more moderate. And also, in the same study, we looked at a small sample of liver cancer cases and found a prevalence of this aflatoxin exposure, aflatoxin-related mutation that was much higher than what you would say what you would see in places like the U.S. or Europe. So what did we do? We set out to do this project where we tried to expand our initial assessment of aflatoxin circulating levels of aflatoxin using National Health and Nutrition Survey data, a biobank that's existing. We also aimed at understanding what was the prevalence of aflatoxin associated the mutation, and tried to demonstrate our capacity to recruit liver cancer cases, prospectively trying to think on the possibility of really studying liver cancer in Mexico using some of the approaches that we've shown before and we have extensive experience, which is doing a population-based case control study. So again, for estimate the circulating levels of aflatoxin, we used data from these are representative data from 5 states in Mexico, but coming from the National Health and Nutrition Survey. The detection of the aflatoxin determination was done by Dr. Groupman in Baltimore, which uses a state-of-the-art measurement methods. And we really aimed at understanding the prevalence of detection and exposure levels. So these are the characteristics of the population. These are the different states. These are all high burden states for liver cancer. And as you can see, there's a really high intake of corn tortillas in those states. What did we find? This is the the risk factor distribution. This is what we had seen before: low prevalence of viral factors, but a high prevalence, particularly of women in the metabolic syndrome. This is what we found. This is the prevalence of exposure. Again, we demonstrate that this is ubiquitous. There is some heterogeneity across different states. And just as a comparison, using the same method, the prevalence of detection in the US is less than 1%. However, as toxicologists will say, it's really what matters is the dose, not the presence of the toxin. So when we looked at the levels, what we did find was that although these were lower levels than what we saw, for instance, in Guatemala, these at least for one of the states, the state of Veracruz, this is comparable to what's been observed in Guatemala. We looked also at subpopulations and found that it was, we found that it was more, we had higher levels in rural population, and as expected, higher levels in lower socioeconomic levels, as well as a trend towards higher levels of exposure in older individuals. So just putting these levels in context, I think what we found is that what we found in Veracruz is really similar to the most recent results found in Guatemala. Now we know there's a lot of variability, and this is really a photograph of the exposure, and so we really need to start thinking about monitoring aflatoxin exposure in the population over time. Now, the other interest that we had is understanding what were the sources of aflatoxin levels. So we tried to look at maize and aflatoxin levels. Again, this is a population with very, very high intake of maize. And this is what we found. We found a direct relation. Most of the maize, 80% of the maize, was consumed in the form of tortillas. Now, what I think is really important is that apparently it is the homemade masa tortillas that are driving the levels of aflatoxin in this population, and so this would point to we're talking about populations. The ones that do the homemade corn masa are like the more rural and lower socioeconomic population. So what are the public health implications? I mean, again, we're still, this uncommon pattern of hepatocellular burden is not fully responded with our work, but I think we now need to start thinking about metabolic disease as an important factor that may actually explain the burden that we're seeing. We did see a really high prevalence of detection of aflatoxin. However, the levels are moderate. This really, whenever I present this in Mexico and to Mexican authorities, people are really surprised. This is completely under the radar. Under the radar for the public health community. However, the food production community has been aware for many years that aflatoxin contamination of maize is very common. I think that we need to start to monitor with more care the human exposure to aflatoxin, and also start defining what will be the most important interventions to mitigate exposure to aflatoxin in Mexico. There's been some talk of biological control, but I think that we should spend more time on trying to work with communities for the post-harvest management of the maize, and ensuring that people have access to dry storage facilities. This is getting harder and harder because before rainy season was pretty well defined in Mexico, but over time there's a lot of uncertainty now, and the rainy season is no longer the rainy season. So definitely the climate crisis may affect our capacity to deal with aflatoxin contamination of grain products like maize. Now, moving to colorectal cancer. So colorectal cancer is the leading cause of cancer mortality in Mexico, and it's the third most common cancer. I want to show you this work that we did, where we demonstrated this, really accelerated increase in colorectal cancer burden. Again, this is still remains, as compared to high development index countries, where still the risk is lower. However, the pace at which colorectal cancer is increasing in Mexico is really something that worries everyone here. And when we talk to different healthcare provider and social security organizations, they're very worried about the burden on those institutions of colorectal cancer. And one of the things that we found also is that, as you might expect, the vast majority of these cancers are metastatic and locally advanced when they begin treatment, and as such, really our 5-year survival is at 50%, which is importantly lower to countries in the US or to the US and European countries. So we have a really poor overall survival. So CRC screening is really urgently needed in the country. So I do want to, talk about this a collaboration that we established and that's really driven or initially driven all of the work that we've done on colorectal cancer. And a shout out to Kathleen Van Loon, who's been a leader in this collaboration that was initiated a few years back. And I think that that it's really a demonstration of how to collaborate with global partners. And really, it's been through their support, their institutional resources, that we were able to conduct several pilots and feasibility studies in this. So this is one of the things that we started doing. There were a couple of colorectal cancer screening programs that had already really limited programs that had already been done in Mexico, but had not been documented. So again, this collaboration with UCSF allowed us to help clinical leaders to evaluate those programs and take them into publishing. And we were able to demonstrate that the results of, again, in very controlled conditions were promising. We also, and again with support from UCSF, tried to identify barriers and facilitators for colorectal cancer screening in a low-income urban community in Mexico, and we really found really important barriers and that need to be addressed. So again, we realized that we needed to be very careful about, even if screening is feasible, about what is feasible in each and every healthcare setting in Mexico. So with support from the Prevent Cancer Foundation, we attempted to do a first population-based to assess the feasibility of population-based colorectal cancer screening. Again, using sort of an implementation science approach. We basically wanted community health workers involved in door-to-door vaccination campaigns to also offer fit to households where there was an eligible member. We worked a lot in the development of educational materials to approach a community. And while I think we were able to, we were only able to provide very few fits because to the community because COVID hit. However, in this very small group, we were able to see that there was a good return of the kit to the health center. So we provided the kit at the person's residence, and the residents, actually 71% did come to the primary care healthcare clinic and brought back their fit kit. So again, I think that we demonstrated that in this urban setting in central Mexico City, that screening could be feasible. So we then went on to try to understand the feasibility of doing this in a different healthcare setting, which is a social security system where we have assured the diagnosis and treatment. And so we went and found this small institution in northern Mexico. It's called León in the state of, in the city of Monterrey, bordering Texas. And we did, again, a feasibility study where we selected 300 individuals within that health system and tried different strategies to provide them with a fit kit. So this is more it was an outreach test of or trying to identify outreach activities. So we did so first. This is a health system that, while small, is this health system is very similar to the national federal health systems, which cover close to 60% of the Mexican population. And so what we did is we selected those 300 individuals. We first sent them an email. Then we tried an automated phone call. And then we sent them, we tried calling them and navigate them through the process and invite, again, all of them received these 3 steps, the email, the phone call, and the navigation call. And as you can see, this is sort of the patient flow. And what you can see is that, when we were able to bring a lot of people into the first appointment, close to 40% of the eligible individuals. Out of the eligible individuals, 30% accepted the fit, and the return fit, again, was 30%. However, as you can see, within the individuals that were already there, the return who received the fit, the return was pretty high, it was around 83%. So again, it was a feasibility study, and it was really for trying to understand all the processes that would be needed to be conducted in this specific health system. Now, so we ended up having, I think, an acceptable, culturally appropriate, feasible program. So we recently received funding for a center in Mexico that it's called the Listos for Cancer Control, which stands for Leveraging Implementation Science to Optimize Strategies for Cancer Control. Now, just to point out, Listos in Spanish means smart and ready. So I think that really the wordplay is really key to understanding why we think this is really the future. This is part of an NCI initiative to do more implementation science globally. And we have specifically a colorectal cancer research project where we want to adapt and implement colorectal cancer screening program. So I'm not going to go through this. It's a bit different, but we want to see, we're really more worried now about fit return. So again, these are the evidence-based interventions for fit return that we want to assess. These are different ideas of the implementation strategies that we could use to support those evidence-based interventions, and our primary outcomes are both effectiveness and implementation. So we're going to be conducted based on this conceptual framework. We're going to adapt evidence-based interventions and design implementation strategies to support those evidence-based interventions. And we're going to evaluate the effectiveness and the implementation outcomes using a type 2 hybrid randomized clinical trial. I won't go into detail for this. And one of the key things is we're going to, because this is really important for the health providers, is estimating the cost of implementing a program. And again, we're in the process of developing a costing framework and estimating direct costs and doing an economic evaluation. And this is, our initial ideas for scaling up a program like this is that, again, as I said, León is it's a relatively small institution with that cares for 130,000 individuals. However, I think because it is modeled after the large social security systems, I think it will be very informative on how to implement this at a much larger scale. And again, we're starting to think about a research stratified approach to colorectal cancer screening. So I think what we found is that colorectal cancer screening is feasible in Mexico. And however, we need to work on context appropriate interventions in Mexico. So I really want to thank our funders. The NIH has been very supportive for all of this work that we've done. I want to thank particularly a couple of trainees, students, Leticia Palma Novet, who have been involved in all of this work. Also, the leaders in the Mexican teachers cohort. These are epidemiologists who've been working for a long time. They're no longer at the National Institute of Public Health, but it was thanks to their work that we were able to conduct this. And again, a lot of institutions that have supported us over the years. Thank you very much.
Wonderful. Thank you so much, Dr. Lajous, for a terrific presentation. We will now open the session for our Q&A. We invite you to turn your cameras if you feel comfortable, and so we can see each other during our discussion. And as a reminder, please type your questions in the chat box or use the raise hand feature found under reactions, and I'll be calling on you if you raise your hand. And then please unmute yourself and ask your question. We'll get to as many questions as we can in the time we have left. Maybe I can go ahead and get us started with one question as we wait on others to write or figure out their questions and raise their hands. So thank you for sharing this fantastic information, Dr. Lajous. I am very curious about sharing the findings of your studies, like for instance, the intake of carbohydrates or aflatoxins back to the public, and how you involve communities later on to feed, you mentioned how these findings have informed policies, but I'm curious about trying to help the general public understand, better management of aflatoxins, for instance. So I'm curious about your experience on that aspect and who we need to involve in that conversation, for instance.
Okay, so specifically for aflatoxin, this is again most of the the dissemination of our results has been really done within the, I would say, the clinical community. And so I have presented, I've tried to present these results in areas where this work was conducted, specifically in the Yucatan and in Yucatan and in Chiapas. But again, we haven't been able to do it all over. We've and what's really surprising, I always show my first slide to the clinicians is showing what you quoting the Harrison's Internal Medicine textbook that does not mention aflatoxin as being important in the Americas. And so to point to the fact that there's within clinicians, they are really unaware of aflatoxin being a problem. So we're really starting with that. Again, these results remain unpublished. We're still, we're trying to, I think that once the one that I think is going to be very important is the one on maize and aflatoxin. And we definitely haven't, and we have engaged with Mexico's agricultural, the Ministry of Agriculture to show these results, and more recently with people involved in the incoming administration. So from policy perspective, we have engaged again with policymakers and clinicians, but I do recognize that we have not been able to disseminate this to the wider public. However, we are the National Institute of Public Health, and we try to do this through different seminars to the public. Now, for the Mexican teachers cohort, we've done a lot of work there. So we really are, for us, it's really important to bring to, at least for the community of teachers, not only participants. So we do a monthly video conference where we talk about results on the cohort, but also talk about health in general. And so we try to, we think it's very important to do that because, again, we always get this feedback from our teachers saying, "Oh, we've given you all this data. Like, how does this, what are you doing with the data? You haven't said anything about my health." And then we have to explain that it's not about the person's health, it's about the population health. But, there's really I would say there's still a gap between the generation of the data and then bringing it back to communities.
Thank you, Dr. Lajous. Julia?
Thank you so much for your presentation. It was really extensive and I learned quite a bit. And so thank you. I'm very excited for your work with colorectal screening. One question I had in particular was regards to the sugar consumption and breast cancer in premenopausal women. And I just noticed that there wasn't a dose response relationship. It was really just kind of over 31. And I guess it was grams. And I was wondering if you had any comments on that.
Yeah, I think that we did it based. I mean, the categories were based on so what we were trying to do, the categories were based on the recommendation of how much you should, what would be like, what you should be consuming, no more than 30 grams of added sugars per day. So that was what it's based on. So, but I mean, I agree that we should be trying to understand maybe at the very lower levels how that is changing, because that's really important. So even at lower levels, you're getting, you're increasing the risk. So that was the reason why it just jumped up very quickly, right? Because it was like 30, 60, 90, and 30, less than 30 is sort of the recommendation of not going beyond that. So we tried to make it, I mean, the thing is, we're concentrating on added sugars because we tried, again, to make it as something that was translatable to individuals. I mean, the problem with glycemic load and glycemic index is like, what's your recommendation there? Like, oh, don't have a high glycemic load diet. Like, that is really hard. Added sugars, it's something that you can sort of more easily translate into people's lives. So that was, I think, that's the reason. But I agree. I mean, we definitely need to understand, how it works at lower levels.
That's really interesting, your approach with the public health messaging and as part of your analyses too of how to navigate that across all these topics. Thank you.
Any additional questions? Yes, please, Neil.
Hi there. I guess I have just a general, perhaps more naive question from someone who's not really well researched in the field, but just interested. Do you suspect that in these other cancer types that you'll be considering, that you would also see this effect of glycemic index or this effect of sugar in these Mexican women specifically? When compared to like the usual data that's taken from Europeans or other populations?
So, so I think that, I mean, clearly for colorectal cancer, this will be the case. Not so much for, again, part of the reason is that, I mean, part of what we're trying to do is really study. I mean, this is an understudied population. We do not know. I mean, theoretically, there's a population where carbohydrate or low carbohydrate intake should have a much higher impact because of the genetic structure of the population. But again, I think that, and also some additional environmental factors. But I mean, I imagine that we're going to see that for colorectal cancer, this is going to be very important. I do not know for other cancers, and that's part of the reason. I mean, if you in terms of the existence of cohorts in cancer cohorts in Latin America, this is the only one. And we don't have, so, and information on Hispanics is fairly limited in the US. So again, we're trying also to see how we can build partnerships with cohorts in the US that have Hispanic individuals, again, to try to see if this translates in populations of Hispanic women living outside, or Mexican, women with Mexican heritage living outside of Mexico. But again, these are all really open questions because there's limited research in the area and in these populations.
Wonderful talk. Thank you.
I think we have time for one additional question. Any last calls? I have one, but I want to give time for the audience to ask it. Okay, I think I'll go ahead. Yeah, so hopefully we have time to discuss this, but on our time before our call today, Dr. Lajous, we were discussing on the issues involving health systems and people at top levels into these conversations. And you mentioned in your work trying to integrate cervical cancer or colorectal screening. And we see that a lot in other types of cancers, in bringing the right people into the table and trying to identify strategies to battle that top-down approach in a way. And we've worked a lot with facilitation and having conversations to develop a shared understanding. So I'm curious about your experience on that, because I think a lot of folks in our audience could learn from that a little bit. And so just curious about your experience with involving health systems people.
Yeah. So I think that, it's been very challenging. It's been very challenging because I think the top-down approach to adopting interventions in these health settings is, at least in the health settings that we worked in, is very common. And there's this feeling that, in these health systems, these are all public health systems, sort of the leaders don't want trouble. They already have, very limited time. They already spend a lot of their time doing, the administrative burden is really high. So they don't want to bring in, their feeling is bringing in more voices is bringing in, opening up for trouble, right? So, and, we're working with this institution, León. And prior to that, I was working with another very similar institution in Baja California. And I get a call from the medical director, and she says, Martin, you are working with my staff is dedicating too much time to you. You are meddling too much in our institution. So I think we should just, have an amicable divorce. And I already had the funding for doing the work. And so I was completely unable to transmit to her the importance of, say, bringing into the conversation the endoscopist that was working in her institution. She could not imagine. So she never let us talk to the endoscopist. And now I'm working with this other institution, and we are still finding, even though we've been working with this institution in Monterrey for the past 2 years, we've done a feasibility study and so on. Last two weeks ago, we said, I presented the importance of having a planning committee for the colorectal cancer program. And the response was, no, we're not going to have a planning committee. We don't want to, this is too bureaucratic. And again, it's really been really hard to transmit that, having these spaces to bring all the stakeholders is really important, and hearing their voices is really important. And they fear that what we're bringing in is more burden to them or opening them for trouble. So again, I don't know what we'll end up doing. Maybe it's just going to be, we're not going to call the planning committee, and we're just going to say amongst us three, or we need to find, again, meta strategies for, implementation strategies. So I think, we're learning a lot, and this also has to do with, evidently some structural and cultural factors existing in Mexico. So.
Well, thank you for sharing your experience, Dr. Lajous. I think that concludes our session for today. Again, a very special thanks to you, Dr. Lajous, for joining us, and all of you for being here today. Please remember to join us for our next session on October 10th with Dr. Jennifer Moodley, where she will discuss breast and cervical cancer prevention in South Africa. And once again, please visit our website, cancer.gov/global health, to find information about upcoming seminars. You will find the recording from today's session, as well as past recorded sessions, information on funding opportunities, events, news, and more. And then please follow us on X at NCI Global Health and on LinkedIn as well. Thank you again for joining us. And thank you again, Dr. Lajous, for your presentation today. It was a very insightful conversation.
Thank you very much.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.